Good morning. We're still in the morning, so I'm supposed to talk about TB in special circumstances. Right. So childhood TB has already been dealt with. So pregnancy, newborn also talked a few things about newborn TB. So I'll mainly talk about pregnancy, renal disease, and liver diseases. And in the next lecture, the immunocompromisations will be addressed. So we'll start with the TB in pregnant and lactating mothers. So pregnancy itself is not an immunocompromised status. So usually we don't see any difference in the susceptibility to TB in pregnancy. So pregnancy does not by itself worsen TB unless the patient has any other immunosuppression which coexists with the pregnancy. However, tuberculosis, when present in a pregnant mother, can cause many maternal and fetal complications, especially fetal complications like preterm birth, low birth weight, UGR, and also perinatal mortality. So it's very important that we be aware and also be vigilant when there are pregnant mothers with suspected symptoms. So the symptoms usually are, it's not different from any other patient: chronic cough, weight loss, fever, and night sweats. Again, like mentioned in the previous lecture, where these symptoms are very common in like in pediatric population, even in pregnancy, you get a lot of constitutional symptoms, night sweats, fever, breathlessness. So sometimes patients attribute these symptoms to the normal status of the pregnancy. However, if somebody is having chronic cough and again the weight loss, because weight is not stable during pregnancy, we know there's a weight gain. So when there's a weight gain, it's again becomes very difficult to assess whether there's a weight loss as well. And as mentioned, constitutional symptoms may commonly attribute to pregnancy. And also, not only that, the investigations like blood counts, the white cells, and the ESR, also we know that they are raised in pregnancy. So what about the weight loss? Usually in pregnancy, a healthy mother would, in the first trimester, would have about 3 kilos weight gain, and then about 0.5 kilo per week. So that we have to see whether there's adequate weight gain rather than weight loss when the patients are suspected to have tuberculosis in pregnancy. This is about the white cell count. Again, we know that during the first trimester, white cell count can be normal, but then towards the mid trimester and also the late trimesters, the white cell count can be even high up as around 15,000, and of course it can go further up during the labor and the postpartum period. So again, we get into some challenges when diagnosing tuberculosis. So same with the ESR. It can be around 100 even, usually 70 during the second trimester, and it can go up further during the third trimester. So these things also need to be kept in mind when you are evaluating a pregnant mother who's suspected to have TB. So one of the most important investigations, chest X-ray in diagnosing pulmonary TB. So I ask this question from when I do the chest X-ray class for my students: is chest X-ray contraindicated in pregnancy? And I'm not going to ask this question here, but then you'll be surprised that about half of them would say yes, it's contraindicated. It's not contraindicated. So chest X-ray can be done at any point, but there's common phobia among patients, and not only patients, among the healthcare staff, especially doctors. We are also concerned and worried when we want to do an X-ray in a pregnant mother. So if you really want to avoid, that would be the late first trimester and the early second trimester, because it's very important that whenever a mother is having prolonged persistent symptoms, you need to diagnose. If the chest X-ray is indicated, you have to do it. We have seen patients who have been undiagnosed for many months because anyone has not done a chest X-ray. Sometimes TB, sometimes other infections, sometimes even with masses, can be even malignancy. So if you want to avoid, maybe the neural development of the fetus maximally occurs during the late first trimester and the early second trimester, about 10 to 20 weeks. So even during that period, you can have a abdominal cover and leg diaphragm, and then you can do a chest X-ray. This graph shows that the usual cumulative, the safe radiation dose. Here, there's a cutoff of 5. This is the old units, red, and these are chest X-ray is very negligible. So the radiation of chest X-ray is very negligible. You can do a chest X-ray very safely. Even CTs you can do. In other countries, of course, patients come with pulmonary embolism, suspected embolism in pregnancy. There's no hesitation to do a CTP. Yeah, so that's one message. Diagnosis is somewhat challenging, but then you have to go with the history, the absence of weight gain, and also chest X-ray findings. Once you diagnose, of course, you do the same diagnostics testing like sputum and MAN2. So all these things can be done in pregnancy. There's no change in the diagnostic algorithms in pregnancy, and the basic principle of treatment would also remain same. You can start treatment at any point. You don't have to delay the treatment, and the treatment regimen would be the same: 6 months of treatment with the 2 months of intensive and the 4 months of continuation phase. And it's advisable to give pyridoxine with isoniazid to avoid the dermatological manifestations. Importantly, streptomycin has to be avoided because there can be fetal ototoxicity if given streptomycin, and also rifampicin when given during the 3rd trimester can cause hemorrhage, postnatal hemorrhage in the newborn. So the babies can be given with vitamin K supplementation during birth. So otherwise the treatment would be the same. That's about pregnancy. So when the mother is having tuberculosis, then the next question is about the child. So that was dealt with by Aruna to a certain extent, about congenital TB or the perinatal TB. So congenital TB is a rare but serious form of TB with a high mortality rate if not treated promptly. So TB, as discussed earlier, can be transplacental or it can be even aspiration from the amniotic fluid during the delivery, and also it can occur after the delivery as well due to aerosol spread. So as mentioned again, the primary focus would be the periportal area where the placental blood comes and gets the infection. So it's very important that the newborn's liver and the periportal area thoroughly evaluated for possible tuberculosis, the lymphadenopathy and hepatomegaly. If not treated, it has a high morbidity and mortality, and early diagnosis and prompt treatment improve the outcomes. Again, newborns commonly present with lethargy, failure to thrive, irritability, again very non-specific symptoms. So there has to be a very thorough clinical examination to look for hepatosplenomegaly, which is all present in almost everyone, all children, all newborns with congenital TB. Then abdominal distension, lymphadenopathy. So, and also they can have other systemic involvement, even meningitis, miliary TB, septicemia. You can see all the list here, but the commonest would be meningitis and the miliary tuberculosis in the lungs. So this is a chest the X-ray shows ascites and abdominal distension, maybe widespread lung involvement in congenital tuberculosis. So there is a diagnostic criteria. So the primary complex would be around the liver, because that's again the portal of entry. So lesion in the liver, the first week of life where the TB infection is present. So to exclude postnatal transmission from the mother, and also the placental and the genital TB. So generally, if your mother is having TB, we always take a sample of the placenta for microbiological tests. So that we always advise to the obstetric team. And if the child or the newborn later found to have features of congenital TB, then that helps for a retrospective diagnosis. So of course the diagnosis, chest X-ray and abdominal ultrasounds are must. Then of course based on the clinical picture, you do the rest of the investigations: gastric aspirate, liver biopsy, CSF analysis, placental testing, and the gene expert, of course, can be done. So the diagnosis of congenital TB again is important because we have to treat. Of course, sometimes if there's strong clinical suspicion, we have to start treatment without delaying because it has a high mortality and morbidity. So if the mother is sputum positive, then of course for the infant we have to give, that is mother is positive, so there's a high risk of transmission. So INH prophylaxis need to be given if the child is healthy. Of course, if the child is having congenital TB, that is for the full treatment. But if the child looks healthy, there's no congenital TB, then still the child needs INH prophylaxis for 3 weeks. And you saw the guide, the algorithm earlier. And after 3 weeks, we do the MAR2, and the BCG vaccination can be delayed until then. And if the MAR2 is positive, we have to extend the prophylaxis. However, if the mother is non-infections, that means a sputum negative TB, or mother has already completed treatment before coming to the third trimester, then of course no prophylaxis is needed. Breastfeeding is strongly encouraged in lactation. So even if the mother is on anti-TB treatment during the postpartum period, still the breastfeeding is encouraged as the benefits outweigh the risks. All first-line anti-TB drugs are compatible with breastfeeding. They secrete in very minute amounts, which does not affect the child. However, if the mother is still on treatment, they are advised to wear a face mask, and also to avoid coughing to the child's infant's face, and also not to share the common breathing space. So those precautions need to be taken, and mothers need to be advised on these things. The contraindication would be TB and HIV co-infection. Then of course the breastfeeding is contraindicated. And also it will be very difficult if the mother is having extensive and untreated drug resistant TB. But still, it's not a contraindication, but you can advise for expressed breast milk. But if the mother is having HIV, then of course it's not recommended. So BCG vaccination was discussed earlier, so I don't think I have to go through this one. It's the same. So if the mother is having positive, then of course you delay the BCG vaccination for 3 months. Now that's about TB in pregnancy, lactation, and also a little bit about perinatal tuberculosis. Then so the important points would be the mother's health is very important, so you have to do everything to diagnose, including chest x-rays and sometimes HRCTs if really necessary, and the treatment cannot be delayed. In chronic kidney disease, so in CKD, there's immunosuppression due to many reasons. Due to complex pathophysiology, there's uremia can cause immunosuppression. There's malnourishment, and also commonly they have coexisting other diseases like diabetes, which can again cause immunosuppression. And of course, if the patients are on dialysis, that adds to the immunosuppression, because we know that in dialysis there's a lot of this the antibodies can be so you lose the antibodies, so the immunosuppression increases. And also after transplantation, patients are on immunomodulators, again patients are grossly immunocompromised. So the same here, you can see how uremia can cause. So it's a very complex mechanism, dysfunction. Then the dialysis also add to that. Then there are the drugs. Then there's patients are having comorbidities. So ultimately, the patients are having a lot of immunocompromisation. So tuberculosis is more prevalent among CKD patients, especially in patients with who are getting dialysis. It is said that TB is 6 to 16 times higher in CKD patients who are undergoing hemodialysis. And often it would be atypical or extrapulmonary tuberculosis, pleural TB, lymph nodes TB, and also peritoneal TB. And as mentioned in the earlier lecture, you know that these patients need invasive testing, and the diagnosis again becomes a challenge, especially when it's pleural TB. Patients with uremia, they are having effusions, uremic effusions, which might have a very varying clinical presentation. Sometimes it can be transudate, sometimes it can be exudative, sometimes it can be hemorrhagic. So uremic effusions, it really makes the picture very complex. And also patients can have this venous thrombosis because of all these lines, neck lines, and they can have effusions, and the patients can be nephrotic and they can have effusions. So when they're having pleural TB, it's very difficult sometimes to diagnose. So you need to go for a thoracoscopic, and you need pleural biopsies. Yeah, and also of course you need TB PCR or gene expert testing sometimes, because again this is a post-bacillary status, and you might not find the AFBs are going to be negative in your pleural fluid cultures. Sometimes it become positive, but it takes a long time. So gene expert is important, and the TB PCR important. So lymph nodes and peritoneal TB also can occur in these patients. Again, with pulmonary TB also, they may lack the classic signs like cough and hemoptysis. It can be very indolent and very insidious onset and a very slowly progressive disease. And sometimes, unless you do a chest X-ray and diagnose, it's very difficult to. The clinical diagnosis might be delayed. And also, the patients are anyway they are having fatigue, weight loss, fever, night sweat. So you know that is again the symptoms are also not going to help you much. Sometimes even spinal TB again becomes challenging because they already have this osteodystrophy. So the spinal changes are anyway there. So likewise, it makes the picture very blurred. So sometimes these diagnostic challenges are there. And also the Mantoux test. You know that in immunocompromised people, patients on a lot of medication, the Mantoux can be negative. Sometimes you go for a lower cutoff, especially you'll see in the next lecture, in the immunocompromised people, you go for a lower cutoff of 5 millimeters. In CKD, it's not. There's no consensus like that, but still the Mantoux can be negative. So interferon gamma would be a better way of assessing for TB exposure. It does not, again, I think it was mentioned earlier during the latent TB lecture. So this does not say that there's active TB, but it will say that there's TB exposure, and the patients are having the memory cells, the memory T cells in their system. So interferon gamma, if available, it will be good, but then again it's some 20,000 rupees, and not everyone can afford that. So commonly the patients need gene expert cultures and invasive testing like biopsy to arrive at a diagnosis. This is our picture in Anuradhapura, where I was also involved when I worked there. We had about 300 patients with advanced CKD, that is stage 4 and 5 CKD, who got TB. No, there are about out of all CKD patients, there were about 300 plus patients for 2 years, these 2015 and 16, and of them, sorry about the poor quality, about 50 were having stage 3 and 4, because creatinine clearance we go by 30, cut off 30. The treatment also changes after that. If the creatinine, if they are having CKD stage 4 and 5, then of course you have to alter your treatment regimen as well. Of course, you can see here the symptoms do not change much. They are all having the same, more or less the same TB. This is pulmonary tuberculosis. Not, we have excluded it is not the extra pulmonary TB. The cough would be the commonest symptom, with loss of appetite, loss of weight, fever. So interestingly, when we tested them, acid-fast bacilli was in advanced CKD, that is stage 4 and 5. The sputum was very scanty. Majority it was grade 1, that is only very small amount of AFB, and also scanty. So that is very, look at the microscopy, there's a very little acid-fast bacilli that you can see. Compared to non-CKD, non-advanced CKD, that includes the normal population plus stage 1, 2, 3 patients, they are having a more positivity, 3 plus and 2 plus. So you will see in the next section that again in immunocompromised patients, they are very post-bacillary compared to the immunocompetent patients who have more lung destructions and they are having open pulmonary TB, high transmission risk also, but also when you try to diagnose, sputum AFB becomes very highly positive. So that difference was noted here. So that again makes diagnosing TB in advanced CKD stage 4 and 5 difficult, because your sputum also going to be very scanty. The cure rate also, it was 90% versus 98%. So advanced stage 4 and 5, they had a higher death rate. Treatment, of course, the main two pillars of anti-TB treatment would be isoniazid and rifampicin. So they are of course having a liver biliary excretion. So of course no dose change need in renal disease. However, pyrazinamide and ethambutol, uh, they have a significant renal excretion, and therefore if you do not adjust the doses, the metabolites the concentration can increase, and that can cause increased liver damage. So of course ethambutol and pyrazinamide, you need to dose adjust according to the stage of CKD. So in stage, if the creatinine clearance is less than 30, we usually go for every other day pyrazinamide and ethambutol, that is 3 times a week. Streptomycin should better be avoided because we know it can cause nephrotoxicity. Of course, if essential, we can still give about 2 to 3 times a week with levels being monitored. So you can see here, isoniazid and rifampicin can be given daily if wanted, or else you can have other different regimens. But pyrazinamide and ethambutol, you need to make it every other day or 3 times a week. Yeah, the same thing here that you can see during, of course, if it's a mild CKD, then of course you can give the same regimens, but in advanced CKD, you need to adjust the doses. So when do you give the drugs if the patient is on hemodialysis? So ideally, the most preferred timing would be post-dialysis, because then that preserves the drug doses, and it avoids premature drug removal. Otherwise, if you give it pre-dialysis, during the dialysis, your drugs all will be removed. So post-dialysis, but the problem is then the drugs are there for a longer duration in the body, and it can increase the risk of nephrotoxicity. But however, that is preferred, and also with more treatment adherence. But if you are really worried about the nephrotoxicity, then of course pre-dialysis about 4 to 6 hours can be given. So we need to liaise with the nephrologist when these patients are on dialysis, regular dialysis, when to give and what to give and what other regimens that we are going to use. In transplant recipients, the patients who already had kidney transplantation and on immunosuppressive treatment, so again, as we know that TB is a significant problem, so their incidence is high, reactivation or primary infection both can be increased. And latent TB, if we diagnose latent TB in transplant immunocompromised patients, of course we need to treat them, because in a normal population we know that latent TB, if you diagnose in any one of us, maybe we have only about 5% or maximum 10% lifetime risk of developing active TB. However, in immunocompromised patients, it's very high. It's, in HIV patients, it's almost 1 in 2, 50%. So similarly, in the transplant recipients, we try to treat latent TB with INH prophylaxis. When treating diagnosed pulmonary TB in transplant recipients, the problem would be the rifampicin can cause a lot of interactions with these calcineurin inhibitors like cyclosporine, and also with MMF and tacrolimus. Therefore, we have to adjust the dose very carefully, and sometimes you might need to go for a non-rifampicin regimens as well. So that again need to be liaised with the nephrologist. And sometimes these patients are on steroids, and when, again we know that rifampicin can cause through the cytochrome 450 system that can increase the steroid metabolism. So we have to double up the dose of the steroids. What about liver cell disease? Only a few slides here. So in tuberculosis, if you diagnose the pulmonary TB patients, that's usually they have asymptomatic liver involvement. If you do the liver enzymes, we generally do, and it's not uncommon that they have a mild elevation of liver enzymes. Even up to 3 to 5 elevation is taken as you are not much worried about that. Because they have granulomatous hepatitis, which is asymptomatic, it's not uncommon. So, but you don't worry about that. You just treat with anti-TB drugs. However, if the patient is having pre-existing liver disease, that might be a concern, because in patients with pre-existing liver disease, when you start anti-TB drugs, especially all these 3 drugs, rifampicin, isoniazid, and pyrazinamide. So those are the main 3 drugs of anti-TB. Then all 3 are hepatotoxic, and also the drug-induced liver injury, the chances are higher in these patients. And also in chronic liver cell disease, the diagnosis again become difficult because they are having more of extra pulmonary TB rather than pulmonary TB. If you look at the drugs, you can see here pyrazinamide would have highest hepatotoxicity, followed by isoniazid and rifampicin. Ethambutol and the streptomycin, they are usually liver friendly, so we are not worried about that. But of course, pyrazinamide would be the main culprit, followed by isoniazid and rifampicin. If you come across a patient with a hepatitis carrier or a past history of acute hepatitis who is now resolved, clinically stable, excessive alcohol consumers, of course, those patients you are not too worried. You can give a normal regimen of anti-TB treatment, provided their liver functions are stable. However, we have to keep in mind that these patients are also at a high risk of developing drug-induced liver injury. Therefore, you usually monitor them very closely. Liver functions has to be done weekly for the first month, and then at least monthly. So if the liver enzymes are about 2 to 3 times, below 2 to 3 times, then of course we are not worried. We give the standard treatment. If it is between 3 to 4, 3 to 5 times, then we go for a different regimen. We can omit one of the main drugs like pyrazinamide. So and then of course we can extend the dose. Then that is only 2 hepatotoxic drugs, isoniazid and rifampicin. Pyrazinamide is omitted. But of course, if the liver enzymes are more than 5 times, then the patients are symptomatic. Then we have to go for non-hepatotoxic regimens. That is, those are ethambutol, streptomycin, and levofloxacin. There are other regimens also, but this is the commonly practiced drug regime. And of course, sometimes commonly we have to increase the dose 9 months or even up to 12 to 1.5 years as well. If the patient is having decompensated liver disease, of course we don't give the full dose, full ATT courses with hepatotoxic drugs. We have to avoid pyrazinamide, prefer other regimens as mentioned earlier, and we need to monitor them very closely. But you should not never withhold anti-TB treatment fully. If you have the options like streptomycin, ethambutol can be given, but sometimes of course patients are having liver and kidney disease, then you are of course helpless. You become helpless sometimes. And of course, the common advices like avoidance of alcohol, other hepatotoxic herbs, these arista things and all has to be given. These advices need to be given to the patients. And this ursodeoxycholic can be given for cholestasis, because rifampicin can cause cholestasis. So that's about the special precautions that you take in some very common scenarios: pregnancy and lactation, chronic kidney disease and chronic liver cell disease, which is very commonly there in our wards. And of course, now all patients who are undergoing liver transplantation, they refer to us. We do an assessment. We look for latent TB and we start treatment. So we have a much better understanding and collaboration among our colleagues. So with that, I think I stop my lecture. Thank you.